Today, I'm going to present Doppler in obstetrics, the role of Doppler in obstetrics. It's Dr. Anamul Haque. I'm an infertility and IVF specialist. So, I'll discuss today the applications of Doppler in modern obstetrics. The applications in obstetrics before 11 weeks, basically, there is very little role of obstetrics because the Doppler ultrasound have some negative effect on fetus, so it's better to avoid Doppler in first trimester. In 11 to 14 weeks, we use Doppler for the better evaluation of the aneuploidy screening, especially for the Down syndrome screening, and in the second trimester for the assessment of the congenital anomaly more precisely, you can use Doppler. And obviously in the third trimester in modern obstetrics, there's a great role of Doppler ultrasound for assessing the fetal well-being. So as you all know, in a Doppler, actually in a this is the two flow, systolic and diastolic flow. With these two flow, some common term we are using in Doppler ultrasound that you should know. Commonly use the SD ratio, that means systolic and diastolic ratio, and the resistance index and pulsatility index. The resistance index means it is the systolic by systole minus diastole by systole is resistance index, and pulsatility index is systole minus diastole by mean is the pulsatility index. So these are the term we commonly use in Doppler ultrasound. So what happened actually when fetus is hypoxic? When the more than 50% of the placental function compromise, then mild hypoxia develop and you will get change in the umbilical artery. But when the more than 70% of the placenta non-functioning, then you will get change in the compensatory change in the middle cerebral artery. So this is the mild hypoxia. But when the baby is severe as hypoxic, that means more than 70% of the placenta non-functioning, and in that case all the compensatory mechanism fail and you will get change in the ductus venosus and umbilical vein. In the umbilical venous change you will get. So this is the basic. That means when the placental function more than 50% compared with the mild hypoxia. Moderate hypoxia means more than 70% placenta is non-functioning and you will get change in the compensatory change in the middle cerebral artery. But when the baby is severely asphyxiated, that means more than 90% placenta non-functioning and you will get the change in the venous flow, in the ductus venosus and the umbilical venous flow changes you will get. So the information, that's mean the uteroplacental circulation, the Doppler information you will get change in the uterine and umbilical artery. But the cutoff point, that means when you are getting the brain sparing effect in the middle cerebral artery, this is the cutoff line that fetus in a compromised state. But if you get the venous change, so that means you have to take decision, and because fetus is severely hypoxic, fetus is acidemic, so you have to deliver the baby. So first the change we assess in the uterine artery. Uterine artery, as you know, the first is uterine artery in the subserosal level, it divides in the arcuate artery. Then in the myometrium it gives branch in the radial artery. In the deciduomyometrial junction, it becomes basal artery, and then in the decidua it becomes spiral artery. So the according to gestational age, when the pregnancy is advancing, these changes actually occur. In the first trimester, in the first trophoblastic invasion occurs up to the deciduomyometrial junction, like this. First trophoblastic invasion is up to this deciduomyometrial junction. Then the this trophoblastic invasion occurs in the after first trimester. The second trophoblastic invasion occurs, so this up to radial artery, the whole artery become like become dilated and they have single channel. So this is the normal uteroplacental circulation in the first trophoblastic invasion and the second trophoblastic invasion. So placenta ultimately invade the whole of the up to the level of uterine radial artery. So that's why you will get the changes in the umbilical artery accordingly, like in the first trimester and second trimester. But this is the normal waveform of the uterine artery, and when you will see the uterine artery. But if you see the arcuate artery, that means in the subsural level, you will get the uterine artery flow like that. And if you observe the external iliac vessel, you will see the Doppler waveform is like that. So you have to keep in mind, by seeing the pattern of the waveform, you can identify which one is the uterine artery. So you have to keep in mind that uterine artery is look like that. And so how to detect the uterine artery? It is very easy. You can detect uterine artery transabdominal scan or transvaginally. So first you have to locate the external iliac vessel in a longitudinal view, then just angulate your probe towards medially, then you will get the a vessel that is in the right angle towards the external iliac vessel. This is the uterine artery. So in uterine artery, you have to place the Doppler gate, the Doppler box. The Doppler gate should be less than, angle of inclination should be less than 30 degree, and it should be placed over the uterine vessel. So you will get the accurate Doppler waveform. And the normal waveform, this is the systolic and the diastolic waveform. This is the typical uterine artery flow. So basic waveform at the beginning of the pregnancy, the uterine signal pattern shows high pulsatility with high systolic and low diastolic flow velocities, in addition to an early diastolic notch. So in a first trimester, the early diastolic notch is normal. The notch represents peripheral vascular resistance due to incomplete trophoblastic invasion. That is, if you get pre-diastolic notch in the second trimester, that is abnormal. With continued gestation, vascular resistance decreases due to second trophoblastic invasion. So the end diastolic flow increases, and diastolic notch not seen after 23 weeks. Rest of the pregnancy, there is steady increase in the diastolic flow with lowering of the resistance index. This is the basics of the uterine artery Doppler. That means you can get pre-diastolic notch before 12 weeks. Up to 23 weeks you can get, but after 23 weeks, if you get diastolic notch, this is abnormal. So here, in a first trimester, before the first trimester, you can get pre-diastolic notch, and here you see the systolic flow is higher than the diastolic flow. But when pregnancy advances gradually in the second trimester and third trimester, diastolic flow increases. But here you also see in the 8 weeks the diastolic flow is lower, and the 15 weeks the diastolic flow again increases, and then the 22 weeks diastolic flow more increases. The progressive increase in diastolic flow velocity is a result of normal trophoblastic invasion. When the first trophoblastic and second trophoblastic wave progress smoothly, then you will get the gradual rise of diastolic flow. This is the normal uterine artery Doppler. Here again you see the what is the normal in the first trimester. You can get the pre-diastolic notch because of the incomplete second trophoblastic wave, so you will get pre-diastolic notch. But in the second trimester, basically after the 23 weeks, you will not get pre-diastolic notch, but increase in the diastolic flow. In the third trimester, there is marked increase of diastolic flow. Should be no pre-diastolic notch. And abnormal is when in the first trimester you get the diastolic flow is more. This is abnormal. And the second trimester, after the 30, if you get the pre-diastolic notch and diastole is low and is reverse, is abnormal. So again you see here in this is the normal, that is means increased diastolic flow, but when you see the pre-diastolic notch and decrease of the diastolic flow, it is abnormal uterine artery Doppler waveform. So but you have to remember, during uterine contraction, the peak of the uterine contraction, you can get pre-diastolic notch. You have to wait for the relaxation. During relaxation phase, you will get again the normal waveform. So when you are getting pre-diastolic notch, you have to keep in mind whether there is any uterine contraction. So if uterine contraction is present, then you have to wait for relaxation. Then again you see Doppler waveform. So the clinical significance, the abnormal uterine artery velocities correlate with the preeclampsia, intrauterine growth retardation, increased risk of prematurity, placental abruption, cesarean section, and low birth weight. So the indication of doing the uterine artery Doppler for the screening purpose, basically you can screen for the whether the this pregnancy is going to happen in preeclampsia. For the screening of the preeclampsia and IUGR, basically we are using the uterine artery Doppler, and if the previous or present history of preeclampsia, there is history of chronic hypertension, diabetes mellitus with vasculopathy, maternal collagen vascular disease, recurrent pregnancy loss, antiphospholipid antibiotic, and previous IUGR. These are the indication of doing uterine artery Doppler. So the abnormal uterine artery Doppler are if you get pre-diastolic notch and the PI more than 1.45 and RI more than 0.58 after 23 weeks. The difference between right and left SD ratio more than 1, PI and RI more than 95th percentile, SD ratio more than 2.6 after 23 weeks, and normogram should go down as the pregnancy advances. So this is the normogram where the upper curve showing the 95th centile and the middle curve showing the 5th centile and the lower curve showing 5th centile. So with the advancing gestational age, PI RI should be low. This is the normal. So uterine artery Doppler we use for the screening purpose, and the value limited to high risk pregnancies only. So routine screening not performed. For the screening purposes, if you find the bilateral diastolic notch and SD ratio or PI less than more than 95th centile, that means clinic positive. That means this pregnancy may have preeclampsia, or the baby may be IUGR, intrauterine growth retarded baby may happen. So the interpretation is, if bilateral PI normal, there is a little chance of preeclampsia IUGR, and it is more than 95% negative, it has negative predictive value. That is why for the screening purpose it is very important. After 18 to 20 weeks, if you get bilateral pre-diastolic notch, that is this suggestive that she may have preeclampsia or IUGR baby. And the the evaluation, Doppler evaluation in high risk pregnancies, if you do the Doppler at 18 to 20 weeks, if Doppler is waveform is normal, so prenatal care should be according to normal guideline. But if you get abnormal, then you have to abnormal Doppler waveform, that is pre-diastolic notch or RI or PI is high, then you can start aspirin prophylactically. The current recommendation is you have to start aspirin 150 milligram. Then again at 24 weeks, repeat the Doppler scan. If Doppler waveform is normal, then the routine antenatal checkup. If again persistent abnormal Doppler waveform, then close interval follow-up, and then growth scan, biometry, Doppler at 2 weeks interval. And you have to remember that this pregnancy may have preeclampsia, pregnancy-induced hypertension, IUGR, and placental abruption. So next is the umbilical artery. Umbilical artery is the reflection that it is a placental obliteration. So the umbilical artery is the branch of internal iliac artery that enters into the placenta, and it becomes primary, secondary, and tertiary stem villus. And tertiary villus ultimately form the vascular bed, placental bed. As the pregnancy advances, there is increase in the tertiary stem villi and small muscular arteries, leading to decrease in placental vascular bed resistance. So the umbilical artery reflect the placental vascular bed circulation actually. So the normal PI and RI, if you think that in a second trimester the PI is 1.5 to 2, in the third trimester PI 1 to 1.5, and SD ratio 2 to 3, and second and third trimester, and RI around 0.5 in second and third trimester. You have to remember that. So the umbilical waveform is a first sign of hypoxia and intrauterine growth retardation. So typical umbilical artery waveform is a sawtooth pattern. Here you see this waveform is like tooth of the saw. The upper one is the umbilical artery and the lower one is the umbilical venous flow. The normal umbilical artery flow is a tooth of the saw, and the venous pattern is continuous waveform. This is the umbilical vein. So up to 12 weeks, the normal umbilical artery waveform, you will get the absent diastolic flow. This is normal in the first trimester. But after 12 weeks, end diastolic flow develops, and then gradually progressively increase end diastolic flow. So RI and PI low. So that is why the umbilical artery Doppler sampling not done in early pregnancy. In the early pregnancy, absent of end diastolic flow is normal, but after first trimester there should be gradually increase of the diastolic flow. This is the normal waveform of the umbilical artery. Here again see, in the first trimester the absence of the diastolic flow and the umbilical venous flow is pulsatile. This is normal in the first trimester. But in the early second trimester, the diastolic flow is low, and in the second and third trimester diastolic, gradually there is a progressive increase of the diastolic flow. This is normal. So the abnormal is when the placental blood flow 60 to 70% of the placental blood flow is compromised, then changes in the umbilical artery waveform are evident. And here you see the normal umbilical flow, there is a sawtooth appearance. Then when the diastolic flow reduce, This one here is absent, and here you see diastolic flow is reverse. So reduce, absent, and reverse end diastolic flow is abnormal umbilical artery flow. So why these changes occurs? These changes occur in the as because there is a in the tertiary villi is occluded because of the thrombosis or fibrinoid necrosis or edema. So there is decreased number of small muscular arteries lead to asymmetric IUGR, and that is why this umbilical artery Doppler you can't use as a screening test for IUGR, because when you will get abnormal umbilical artery, that is already 70% of the more than 70% of the placental villi are affected, but IUGR can happen when 40% of the placental vascular bed is obliterated. That is why umbilical artery Doppler you cannot use as a screening test for the IUGR, because IUGR can develop up to 40% vascular compromise, but umbilical artery changes you can detect when more than 70% vascular bed obliterated. So the abnormal waveform is, this is the normal. Then the first trimester we see absent of the diastolic flow, this is normal, but in second trimester and third trimester gradually increase of the diastolic flow. But here you see, if you get in the first trimester, if you get the diastolic flow, this is abnormal. Absent of diastolic flow in the first trimester is normal, but if you get the diastolic flow in the first trimester, this is abnormal. And in the second and third trimester, if you get the reduced, absent, and reverse diastolic flow, this is abnormal. So the reduced, absent, and reverse end diastolic flow is abnormal. That indicates increasing resistance. That means fetus is hypoxic. So if you get the diastolic flow, positive diastolic flow means 12% hypoxic and 0% acidemic. But if you get the absent end diastolic flow or reverse end diastolic flow, 80% baby are hypoxic and they are up to 40% baby are acidemic. So if you get the absent or reverse end diastolic flow, there is a risk to the fetus and the neonate. There is a increased risk of intracranial hemorrhage, increased risk of fetal anemia, increased hypoglycemia, and thereby increased need of NICU admission. And ultimately, there's a long-term neurological damage can happen to the neonate. So if you compare the cardiotocography and the umbilical artery Doppler, so in a modern obstetrics, umbilical artery Doppler waveform is more important than cardiotocography, because the change what you get in the cardiotocography, the late deceleration, when you get the late deceleration, it is too late. But if you get the umbilical artery changes, this is actually more important, because you will get umbilical artery Doppler waveform velocity 3 to 12 days before than the late deceleration of the CTG. That means when you get late deceleration of the CTG, that is too late. But if you get the absent end diastolic flow, that is 3 to 12 days before than the late deceleration of the CTG. That is why in modern obstetrics, the umbilical artery Doppler is more sensitive to CTG, and it is 90% more sensitive to CTG. And abnormal umbilical artery Doppler, when any gestational age, you get RI more than 0.8, and PI second trimester 1.5 to 2, and third trimester 1 to 1.5. This, and SD ratio, if it is more than 3, this is abnormal. Sometimes you can get single umbilical artery, and left side it's 73% and right side 27%. Isolated single umbilical artery is normal, but you have to remember there is a little risk of chromosomal and congenital anomaly, intrauterine growth retardation, prematurity, increased perinatal mortality. So if you get the single umbilical artery, you have to do detailed sonography, detailed anomaly scan to diagnose other soft marker of the chromosomal or structural anomaly. Now the middle cerebral artery. Middle cerebral artery Doppler is more constant actually. It is in the whole pregnancy, the RI and PI more constant. It is the RI 0.75 to 0.85, and middle cerebral artery is easy to identify with 0-degree insonation and providing information on the true velocity of the blood flow. That is why middle cerebral artery Doppler is important. And imaging technique is very simple, and if you get the biparietal diameter, then just shift downwards the skull base at the level of the sphenoid bone, and you will get the Doppler flow. So the normal Doppler waveform is the typical, like this is the typical middle cerebral artery Doppler that has the systolic flow and the diastolic flow. But abnormal, when you call this abnormal, if fetus is hypoxic, then there is a compensatory mechanism. That means if fetus is hypoxic, there is a compensatory, because fetus try to distribute more blood to the brain, heart, and kidney. Brain, heart, and adrenal gland, more blood supply, but there is a vasoconstriction of the gastrointestinal, renal, and lung vessel. So redistribution of the more blood to this brain, myocardium, and adrenal, this increase middle cerebral artery. That is why increase the diastolic flow and the reduced resistance for the compensatory mechanism. So during decompensation, what happened? When the fetus is more hypoxic, then what happened? The brain sparing effect loss, and loss of brain sparing effect is critical to fetal death. And the brain sparing effect when loss, that's determine the proper timing of delivery. So another important term is cerebroplacental ratio, or CPR. CPR is more important. CPR means this is the ratio of the middle cerebral artery and the umbilical artery RI. In normal pregnancy, what happened? In normal pregnancy, placental vascular resistance decrease, whereas middle cerebral artery resistance is almost constant in a normal pregnancy. But in a hypoxic baby, what happened? Just reverse is happen. In the placental level, resistance increase, but due to compensatory mechanism, in the middle cerebral artery, resistance decrease. So in a normal pregnancy, the ratio between middle cerebral artery and umbilical artery ratio, RI ratio is more than 1. But when fetus is hypoxic, this is less than 1. This is more important. It is called cerebroplacental ratio. So when more than 70% fetus is hypoxic by IUCR, or more than 70% of blood placental vascularity is compromised, then what happened? The middle cerebral artery blood flow is redistributed, and 70% of the whole body fluid actually redistributed to the brain, heart, and adrenal gland. And MCA diastolic flow increases, so SD ratio decrease, whereas umbilical artery SD ratio increase as placental resistance increase. So umbilical artery SD ratio more than middle cerebral artery SD ratio, that is the brain sparing effect. And the abnormal MCA Doppler, the brain sparing effect is when the diastolic flow increases, so thereby decrease PI, pulsatility index. When oxygen deficit is greater, then PI tends to rise, which presumably reflects the development of the brain edema. And that is why then reversal of the middle cerebral flow. When the cerebral edema develop, then middle cerebral artery waveform end diastolic flow reduced, absent, and reverse. So these appearance of the brain sparing effect or presence or reversal MCA flow is a critical event for the fetus and precedes fetal death. That's very important. So if you get, this is the cutoff line, when you get the brain sparing effect, that means when you get the more diastolic flow, that is the brain sparing effect. But when you are getting reduced or absent or reverse diastolic flow, that means the fetus in a critical state, you have to terminate the pregnancy. So brain sparing effect here, you see, when fetus is compromised, just compromised, then the diastolic flow is increased. But when you get the absent diastolic flow or reverse diastolic flow, that's mean fetus is highly hypoxic and you have to decide to terminate the pregnancy. So MCA is more sensitive to hypoxia than umbilical artery, because the high systolic flow in the middle cerebral artery indicate fetal anemia, and high diastolic flow in the middle cerebral artery indicate brain sparing effect in fetal hypoxia. So MCA Doppler, now in modern obstetrics, MCA Doppler we use it to detect the fetal anemia, especially in the RS negative mother when fetus RS positive. So in the modern obstetrics, we use middle cerebral artery Doppler to detect the level of the fetal anemia, because it is the non-invasive means. Previously, we detect the fetal anemia by doing amniocentesis. We plotted it in Lilly's chart. Accordingly, we decide whether baby is mildly, moderately, or severely anemic. Here you see, when a fetus is anemic, fetal blood velocity become elevated in response to an increase in cardiac output and a decline in blood viscosity. So middle cerebral artery peak systolic velocity used to detect fetal anemia, and the middle cerebral artery velocity is calculated in centimeter per second, but you have here we converted it to multiples of median. So if 1.5 multiples of median, more than 1.5 multiples of median according to gestational age, then it is called moderate to severe anemic. So middle cerebral artery peak systolic velocity more accurate than the amniocentesis. According to middle cerebral artery peak systolic velocity, there is a reference level. According to gestational age, here you see, like if you see the 28 weeks, the middle cerebral artery peak systolic velocity normal is 4.7 to 0.6. Here, the 1.5 multiples of median means you see 55.4. Accordingly, at a 34 weeks, the peak systolic velocity 62.9 is normal, and 1.5 multiples of median means 73.1 centimeter per second. When this is more than that, that means baby is anemic. Here you see, according to that, you can divide it whether this is mildly, moderately, severe anemic. Here you see, in a 32 weeks pregnancy, if middle cerebral artery peak systolic velocity 57.3, then it is mildly anemic. If it is 66.6, it is moderately anemic, and if it is 75.6, it is severely anemic fetus. That is why this is very important and non-invasive means of detecting fetal anemia. And accordingly, like Lily's chart, you just plot this chart according to gestational weight and the middle cerebral artery peak systolic velocity. You make a curve. The zone is divided in 4 zones: A, B, C, and D. If the middle cerebral artery peak systolic velocity plotted in the A zone, that means baby is severely anemic, so you have to do intrauterine transfusion. But in the zone B, and you have to just observe the fetus and repeat middle cerebral artery 5 to 7 days. When it plotted in the zone C, repeat middle cerebral artery 7 to 10 days interval. And when it is zone D, that's when you can just observe the long interval, like to middle cerebral artery in 2 to 3 weeks. That is the way in a modern obstetric how in a age sensitized patient how we monitor the fetus. So the advantage, the middle cerebral artery has changed the management option of Rh negative fetus, and amniocentesis is no longer required actually. So by doing the non-invasive middle cerebral artery peak systolic velocity, we now manage the Rh sensitized baby and no risk of the fetus or mother. This is very simple non-invasive means of monitoring the fetus. Now lastly the venous flow. In the venous flow, the most important thing is the ductus venosus. As you know, the ductus venosus is the short connection of the umbilical vein to the inferior vena cava, and it carries more oxygenated blood directly to the right atrium. So it carries 45% of oxygenated blood to the fetal heart, and it actually reflects the right heart environment. When the heart failure occurs, right heart failure occurs, you will get the change in the middle cerebral artery. Ductus venosus changes. So in a Doppler form, in a sagittal scan, you will get the ductus venosus, the narrow vessel. You will get the ductus venosus, and you also scan in the transverse scan, so you will get the ductus venosus flow. And the typical ductus venosus flow is a M pattern. There is a systolic and diastolic, and A means atrial contraction. So the typical M pattern is the ductus venosus flow. So abnormal ductus venosus flow means when the AOF is reduced. This is here you see, this is the normal ductus venosus flow. This is the systolic and diastolic and the AOF. When the AOF is reduced, absent, or reversed, this is called abnormal ductus venosus flow. So lastly, the umbilical venous flow. As you know, In umbilicus venous flow, the normal umbilicus venous flow is continuous monophasic. When you get pulsation, single or double pulsation or triphasic, that's abnormal. And when you get change in the umbilical vein, that means baby fetus is in critical condition and there is 50 to 60% mortality rate. So umbilicus venous change is the last. When you are getting the change in the umbilical vein, that means anytime fetus can die within the uterus. So the role of venous Doppler is when you are getting the abnormalities in the umbilical artery. So then you have to evaluate the venous flow, and you have to evaluate the non-invasive way of functional capacity of the fetal heart. The non-invasive way of functional capacity of the fetal heart is to evaluate the venous Doppler. And by evaluating the venous Doppler, ultimately you can detect the optimum timing of the delivery, especially in ICR for lung maturity, because 1 day or 2 day time, 24 hours or 48 times is very important for the lung maturity. Then you can give the steroid to the fetus, and if you give the steroid, you have to wait 24 or 48 hours for the termination of the pregnancy, for the delivery of the baby. That is very critical time. If you are not getting the change in the umbilical venous change, then you can give steroid and you can wait 1 more days, then you can deliver the baby. But if you get the change in the umbilical vein, that means you have to deliver your baby now. You have no time for it, because if you wait for the lung maturity in the uterine life, you will lose the fetus. Fetus can die anytime. So accordingly, in a modern obstetrics now, the intrauterine growth retardation actually staged by the Doppler finding. As you know, when your baby is less than 10th percentile according to the gestational age, is called intrauterine growth retardation. But accordingly, in a modern obstetrics, by Doppler findings, the IUCR now stays into stage 1, stage 2 and stage 3. Stage 1 call when you are getting abnormalities in the uterine artery and the umbilical artery and the middle cerebral artery change, then it is called stage 1. And stage 2, when you are getting abnormality in the umbilical artery and the middle cerebral artery and ductus venosus AOF absent, that is stage 2. But if you get ductus venosus reverse or abnormalities in the umbilical venous flow and abnormalities in the tricuspid trigger, then is stage 3. And all these stages again divided into stage A and B. When amniotic fluid volume more than 5 cm is A, if it is less than 5 cm, it is stage B. That is how now in the modern obstetrics intrauterine growth retardation is divided. So here you see in the umbilical artery there is reduced diastolic flow, and in the middle cerebral artery increased diastolic flow. This is stage 1. And stage 2 means in the middle cerebral artery change, abnormal middle cerebral artery, and the umbilical artery, here you see absent diastolic flow, here you see reverse diastolic flow, and middle cerebral artery, and then in the ductus venosus you see the absent AOF. So this is stage 2. And stage 3 means the reverse AOF and the pulsatile venous flow, venous umbilical venous flow change, and in the tricuspid flow, in the tricuspid regurgitation, in the tricuspid valve. This is stage 3, and all the stages are divided into A and B, and AFI more than 5 centimeter A, and AFI less than 5, it is B. So the outcome, stage 1 means mild IUGR, so you can treat as outpatient, and stage 2 you have to admit the patient for close observation, and stage 3 means there is a high risk of fetal death, so you have to deliver the baby, as because there is a chance of 50 to 80% of fetal death, so you have to terminate the pregnancy as soon as possible. So in a conclusion, in the modern obstetrics, for the screening of the mother, whether she is going to develop preeclampsia or she may have IUGR baby, for the screening you should assess uterine artery Doppler at 18 to 20 weeks. Then for the fetal assessment you have to do umbilical artery Doppler after 24 weeks. So if you get change in the umbilical artery, then you have to assess middle cerebral artery, whether baby is in brain sparing effect or more affected. If you get abnormalities in the both umbilical artery and middle cerebral artery, then you have to assess venous flow. First you have to assess ductus venosus flow, then umbilical venous flow. So the thing is, you have to see the Doppler venous flow in a gradual form. That is, first you have, for the maternal assessment, for the screening purpose, you just see uterine artery Doppler at 18 to 20 weeks, whether she has chance of preeclampsia or developing IUGR. Then for the fetus assessment at 24 weeks you do umbilical artery Doppler. If umbilical artery Doppler abnormal, then see middle cerebral artery. If both the umbilical artery and middle cerebral artery Doppler abnormal, then for timing the delivery of the fetus, you have to assess the ductus venosus and umbilical venous flow. That's the all about today's topic. Thank you for the patience hearing.